urology man.
Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Glad to see everybody here. Got a great show for you today. Hey, if this is your first time checking us out, be sure to check out our website at uronurse.com. Best place to go to learn more about the show, visit the people who sponsor this show, and all of our other podcasts. And you can also check out all of our past episodes. This is episode 169, so you got plenty to check from. Just another reminder, we do put out an audio version, audio only version on podcast, Spotify, iHeartRadio, Amazon, and YouTube Music. That comes out about a half hour after the show ends. So be sure to check that out. So let's get to our speaker for today. Today we're joined by Alex Hughes, advisor for Soundable Health, the team behind ProudP, a groundbreaking app that turns your smartphone into a personal Uroflow and digital voiding diary. Alex will share how ProudP is transforming urinary health monitoring, helping patients with BPH, incontinence, and post-surgical recovery track their bladder function from home. Let's welcome Alex Hughes to explore how ProudP is revolutionizing urology healthcare right from your phone. Alex, welcome to the show.
Thanks, Vic. Again, I'm Alex Hughes. I'm really excited to be here. I really appreciate everybody that's been logging on. I am the lead nurse practitioner here at Austin Urology Institute. I'm really happy to be here.
All right. So let's go right into your show. I'm going to bring up your slides and take it away.
All right. Thanks, Vic. Again, my name is Alex Hughes. I'm out here in Austin, Texas. I am the lead nurse practitioner out here. I've been in urology for about 7 years. It's been my only APP gig. So really where I've been kind of shining here is in BPH. We see all slew of different kinds of patients out here, but BPH is kind of my bread and butter. So when ProudP kind of came onto the market, it's really been very, very good for my patients to be able to monitor themselves. And I'll go into really, really fine details about what ProudP is and how I use it in everyday management. But this is my slide deck on modernizing the BPH care plan pathway and integrating ProudP and digital uroflowmetry into everyday practice. This is a little bit about myself. I did work myself up into the lead APP role here at the practice. So I have other APPs and PAs below me where I've taught them how to do diagnostic workflows and how to utilize all the tools that I will be talking about through my presentation. I do perform all of the procedures for our practice. So I do all the diagnostic cystos and cystoscopies and transrectal ultrasounds. I do the cysto stent pulls. I do axonics lead placements. And I train all of my nurse practitioners on how to do these actual procedures as well. We also have satellite clinics. So the hub of my practice is in the heart of Austin. And then we have Georgetown and Dripping Springs, which is about 12 to 15 miles out north and south of Austin. And I kind of joke that the reason patients move out those directions is to not have to come into Austin. So why this was very important in terms of ProudP and the actual technology that we're going to be talking about today is we utilized UroCuff for our uroflowmetry, and patients did not want to come into Austin to do the P test. So I was doing all of these diagnostic workups because we have disposable cystoscopes. I have a transrectal ultrasound that's portable. So I was doing everything out there. But if I needed to get a urine flow measurement, they had to come to Austin. So I was at the AUA in Vegas this past time, and I did a talk at the AUA about BPH workflow. And I actually saw ProudP during the expo. I went and asked them about it. I really got interested in it. And I love the fact that these patients could do their urine flowmetries at their house, because that is where my patients wanted to stay, is at their house or in the city that they were at. So I also do virtual consults. So I will talk to patients over Zoom, and I can review their entire workup through that matter. So my goal with this presentation is to utilize our tools and clinical guidance to get men off of BPH medications and into an effective, durable treatment that preserves their long-term health. So what are patients currently doing? So this is the current state of BPH patient population. 34% of patients are coming in to your practice saying, hey, maybe I'm getting up more than 1 or 2 times a night. I have a little bit of a weak stream, but it's not worth doing something about. So 4.3 million patients are just watchful waiting. 64% are on medical therapy alone. So 7.9 million patients are on, some form of alpha blockers or 5-alpha reductase or a combination therapy. And only 2% are actually moving into a surgery or procedure. So the 2% are where I'm saying that we really need to start kind of utilizing and convincing or treating patients more, because this is a mechanical problem, and you want a mechanical solution for a mechanical problem. And I go into really heavy details on why I don't like medical therapy. But where ProudP will really come into play are these watchful waitings and medical therapy, and then obviously post-procedural, which I will talk about later. So the problems with the medication first. So there's non-compliance, the cost of the meds, the inconvenience, the lack of effectiveness, and the side effects. My side effects is primarily where I start really talking to my patients and trying to get them off of medications. But the reported compliance rate are as low as 29% at year 1 and 13% at 4 years. So you do not want to have to rely on a medication. And this is really where I start talking to my patients. Sometimes I'll have portal messages for my patient that they traveled, on a cruise and their tamsulosin run out, or they forgot their medications. And those are the kinds of situations you really want to try to avoid. And if you have to rely on a medicine to help you urinate, the last thing you want to do is be, off in Europe and then you forget your meds and run into retention or something along those lines. And then side effects, I talk about those on my later slides, but the inconvenience, having to take these meds, having to rely on meds. One of my big examples that I tell my patients about, I had a patient the other day, this was probably about 2 or 3 months ago, and he came in and he was brand new to the practice, and he was on tamsulosin, finasteride, and oxybutynin. So those are 3 medicines to treat, the symptoms of BPH. It's not even treating the actual problem of BPH, but it's 3 meds that can be relieved with a surgical intervention. So, we have a stack of, actually it's kind of looks like that picture, but we have a jar of pills that I'll actually bring in that has 365 pills. And I'll say, this, if you're on, tamsulosin, or I don't want to run it through so any of the alpha blockers, if you're on one of those a day, then you're putting that jar of meds through your liver and the kidney. And you have to, take those to keep your symptoms gone. You double that when you add finasteride. You triple that when you add oxybutynin. So you do not want to have to be putting all of these meds through your kidney and liver if you don't have to. So this is one of my favorite slides of the deck. So this is kind of saying, looking at the IPSS score, which is the International Prostate Symptom Score, and then the side effects from the medications. So dual therapy, if you're on alpha blockers and a 5-alpha, you're looking at an average of an 8-point to 9-point reduction in your IPSS score. And look at all of those side effects that you can have from these medicines. EJD, or ejaculatory dysfunction, erectile dysfunction are on both of those. Nasal congestion, dizziness, that's from your alpha blockers. Dizziness, headache, respiratory issues, cognitive decline on your 5-alphas. When I talk about finasteride, I will even talk, this is one of the only medicines that I know of, at least in urology, that there is a post-finasteride syndrome out there. When I start talking to my patients about these potential side effects from these medications, they're kind of itching to do something else. And if you can look over here on the positives here, they have a 5 to 7 point reduction with an alpha blocker, and then a 3 to 4 point reduction with a 5-alpha. So again, average, you're looking at maybe a 10-point reduction, which if their IPSS score is 10, that may make a big difference, but then they have to take the pills for the rest of their life. So I really, really, really emphasize medication side effects. So these are personal examples. So from alpha blockers, I just talked about this briefly, but orthostatic hypotension, one thing that I was researching is that it can actually worsen heart failure. So a lot of the patients that we're dealing with are in their 70s, 80s, and 90s, and heart failure is one of the leading cardiovascular things that kind of take patients out. So if you're on a medicine, even though, we're kind of taught that it's a benign medicine, you want to try to avoid worsening any kind of conditions that they have. Retrograde ejaculation, this is the biggest reason that my 40 and 50-year-olds will stop taking this medicine. Now, my personal example, and I tell all my patients this, I had a 76-year-old male patient come into my practice. His IPSS score was around a 17 or 18. He had never tried meds or anything for that matter. So I did the right thing by trialing him on an alpha blocker. 2 days later, I have an ER doctor calling me that my patient had gotten up in the middle of the night, had a syncopal episode, passed out, hit his head on the toilet, had 17 staples across his forehead. Now, thank God that patient was not on blood thinners. I mean, it could have been literally lights out for that patient. So even though these medicines are kind of paraded around as benign lifetime medicines, one thing that we all will say is inevitable is as we get older, you're gonna have other things go on, right? So your blood pressure may get out of whack. Your lipids may get out of whack, diabetes, God forbid. But these blood pressures, diabetes, there's no surgeries to fix those. There's no surgery for your blood pressure. There's no surgery for diabetes yet. There's no surgeries for your statins or your replacement of your lipids besides, obviously healthy diet, lifestyle, those things that we all know about. But there's no surgeries out there. So those medicines will eventually probably come onto your profile. These medications, there are procedures for that you can actually relieve. So why not fix a mechanical problem with a mechanical solution? 5-alpha reductase, I kind of joke when I start talking about this slide. When I first got into urology, Dr. Kaushik Shah is my supervising physician. He owns the practice. He scared me from finasteride ever since I kind of stepped foot onto the clinic floor. Mainly the sexual side effects, but the cognitive decline, they've released that 5-alphas can start to cause some cognitive decline. And so when I start talking to my patients, I'm like, the last thing we want if we do dual therapy on a patient is someone that's going to have orthostatic hypotension and they're confused. That is just setting you up for a world of disaster for these patients. And again, what ends up happening with patients? They end up getting a cardiac stent. They end up being on some kind of blood thinners. So if we can avoid having them getting up and falling, that is our duty to these patients. And by doing that, we take them off of these meds and try to get them throughout something that would actually relieve them, something like aquablation, Urolift, Resume, which I'll go into some details about what we offer at our clinic. So the 5-alphas, they also kind of can obscure PSA levels, right? So out here, we have like these testosterone clinics, which we have a very close relationship with the NPs and PAs that are out there. And they will sometimes message me and want a PSA clearance. So I had a patient that had a PSA of around 3.0, and they were wanting me to clear them for testosterone therapy, but they had put them on full dose of finasteride. And so not only was his PSA 3, it was actually a 6 because you have to double that PSA due to the finasteride. So those are things that can happen, when you're on these medications. And, not every practitioner, not every patient knows to look for these things. And another real life example, and I'm sure y'all deal with this too, is we have all of these online pharmacies, Hims, Hers, blah, blah, blah. And they have their space in the market. I'm not knocking them, but we have a lot of patients that are 25 to 30 years old that are coming into our practice, having all of a sudden loss of libido, ED, and all of these things are usually related to potentially some finasteride that they're taking for hair loss. So all that to say, these medicines have side effects, and we need to utilize our tools in the practice to try to get them off of these meds and into something that's more durable. So the tools, I've talked about this a lot. So when I do these talks across the globe, I really, really emphasize as APPs, NPs, PAs, whoever's out there, utilize your tools. My number one, I kind of say this is my Bible for my practice, is the IPSS score. This is a simple scoring sheet from 0 to 35, and it gives you a good, valid measurement to see how your treatments are doing for your patients. So this is one from aquablation. There's one from Urolift in my clinic. They're all over online. So one thing that we're trying to build on our website is something where it's integrated on the website, and our patients can actually fill this out and look at different treatment options. But the IPSS sheet, I talk about my BPH pathway here in a later slide, but every male patient that's 50 or above is getting this score sheet while they kind of just wait for the provider to come in. So it's a talking tool. So I'll have patients that come in for kidney stones, but if they're 62, they're getting this tool sheet. I'll have patients that are coming in that are 55, that are coming in for testosterone. If they're waiting for me to come in to get them, my medical assistant staff know to hand them this. And then honestly, what I'll do is I'll do my visit, and then I'll kind of look over onto the side of the table, and I'll see their IPSS score is at, a 15. And I'll be like, hey, I see that you're having some symptoms from your LUTs, right? So your lower urinary tract symptoms. Do you want to discuss this? And if I have time, if their visit took 5 minutes and I have 15 minutes, I'll talk to them about it at that time. But if they're, if they run out of time on their visit, I'll be like, hey, let's put a pin in this and talk about it next time. Your bladder ultrasound, your bladder scanner, your PVR machine has lots of different names on it. But I will say there has been plenty of times when I've been doing my visit and, they have an IPSS score and it's a 15, and then we put the bladder ultrasound on them and they have a PVR of like 400. So silent retention is a true thing. So again, utilize your tools. UA, urinalysis, every urology practice has some form of urinalysis machine. DREs, digital rectal exams. We are doing DREs on all of our male patients 50 or above, obviously with their consent. But we still practice this. ProudP, this is what we're going to be really speaking about on this slide deck. And UroCuff, I say that their urine flows are like their sixth vital sign. So this really, really shows kind of the internal workings and the internal pressures of their bladder and if they're having an issue or not. Some of the more advanced stuff that I utilize that a lot of your doctors and hopefully some of your APPs on this program are doing are cystoscopy and transrectal ultrasound. So these are all the tools. And what I mean by that is this is almost your evidence that the patient needs something further. And not all, like you have to utilize all of them. This is not just a one thing shines, is more prominent than the other. A UA alone is kind of useless. The ProudP, even if it has some urine flow issues, is kind of useless without your IPSS score. So all of these things need to use in conjunction to come up with a treatment plan and kind of move forward with the patient. So ProudP, okay, this is, what we're talking about this on this program. It has been a huge, huge help for my patients. So what you have on your screen right now is actually snippets from my ProudP dashboard. And so this is all real world data. You can even see on the far right here, Dr. Shaw. So this is our doctor. These are all of our patients. This is just a small few amount of them. And this is your urine flow measurements. So ProudP also has an IPSS score that's loaded into it. So you can see this at the bottom. This is an IPSS score that was done 9/23 of 2025. And so what I love about this is it gives real-time measurements and it puts the power into the patient's hands. So you can kind of see over here, I'm going to go from left to right here. On your top left one, this is October 21, 2025. So this is all data from this patient. So you can kind of see there's an 8:30 p.m., a 6:11 p.m., a 5:30 a.m., a 8 a.m. Sorry, I'm straining my eyes here, and a 6:21 a.m. But if you're trying to figure out, and I know a lot of y'all are in these boats. So you have a patient that comes in that say he's 55 years old and his IPSS score is 13. And his BSQ is, so your bladder symptom questionnaire is 13. So you're trying to figure out, is this a fluid problem? Is this an overactive bladder problem? Or is it a prostate problem? So if you start them with ProudP, because if you bring them in to do a UroCuff, and I'm not trying to run UroCuff through the mud, it is a one measurement at one time. It can be affected by the coffee you drink in the morning. It can be affected by anatomy. I know y'all probably know what I'm talking about if you've done a UroCuff before, but that's what we utilize. So anatomically, it's been a problem before. And then stage fright. I will literally have patients come into the clinic and say they drive from Georgetown or Dripping Springs, which is about a 30-minute drive to Austin, and they get there and they can't pee. And it's not because they have retention. It's because they have a nurse breathing down their shoulder, or they're just in the room and they got to fumble around with this thing. So this puts all of the data into the patient's hands. And what I can tell you from experience and from all of these patients that have been doing these tests is that you get much more accurate real life data on what their urine stream is. Because also, and I'm sure y'all have seen this before as well too, you get them in, they bring them in, and then, say they have been holding their pee for 4 hours, right? Because that's what we tell them to do. You want a full bladder. They get up and they just go, and they just push that urine stream out like it's no tomorrow. So sometimes I'll get a Uroflow or a Eurocup data that shows them, 40 mils per second, which would tell you they don't have an obstruction, but literally they are just trying to push to get out of there. What you want to see is their natural flow. So again, so this on the far left is just urine flow data throughout the day. So another reason why I like it. So say I'm trying to figure out if it's overactive bladder. So I have had patients that have done their ProudP data, and I will actually count, they'll do 12 urinations in the day, but they're only urinating out 90 cc's, 110. So they're not allowing their bladder to actually fill up. So then I give them a goal, and they can see it on their app, they can see it on their phone, and they will say, okay, I need to hold my urine more. So what I've really been utilizing it as well is bladder training. So I will tell them, okay, every time you urinate, you should be hitting around 200, 250, 300 cc's, and it can actually train them to hold their bladder. The other thing is I have a lot of patients down here in Austin where they drink tons of water. So, there's a big, kind of movement out there about drinking a gallon of water a day, blah, blah, blah. If you do that, then obviously you're going to pee more. So then I can actually see them, okay, yeah, they're urinating, 10 times in the day, but they're peeing out 300 cc's each time. Maybe they're actually just drinking too much water. Or, hey, what happens, when you take your Lasix? If at 8 a.m. you're taking your Lasix and at 9 p.m. you're taking your Lasix and all of a sudden I see your urine flow spike, then I can actually say, hey, this is a medicine problem. Maybe you need to, if nocturia is your big issue, maybe you need to start taking your Lasix at 5 p.m. instead of 8 p.m. So it's been a really huge help with diagnosing these kind of obscure urinary issues that we're not used to really kind of having a fine point way of kind of documenting. And you can kind of see here, the second page, these are the number of tests my patients have done. If you can look at this middle one, look at how many tests he's done. 1,580. Now, I will say that that's overkill. You can see the next one closest is 210, 179. So this can go in the opposite direction to where they are hyper focusing on these urinations as well too. But this is a snippet of the urine flow, so you can actually see where it actually will document 15 mils per second, 10 mils per second. It'll give you your urine volume, Q average flow rate, and your voiding time. Everything you need for insurance approval for aquablation therapy. So that's really where we started utilizing this. We do a ton of aquablation in my practice because it's been doing so well for my practice. And I think if I'm remembering correctly, this is actually from one of my pre-op aquablation patients here. And then they have their IPSS score. So IPSS score, you have to have a 12 or a higher for aquablation approval. But also I want to see them if they, start their meds, right? So I give this as even before medication starting. So like if they start Flomax, I will tell them, okay, go home, do your ProudP data, start your medicines, and then you can do your IPSS score before and after you actually do your meds. And then you can actually equate a decrease in their IPSS, an increase in their flow. They are a great candidate for surgery. If they don't do that, right, if they don't have an increase in their flow or a decrease in their IPSS, maybe prostate issues are not what we're kind of looking at with them. So ProudP, this is another one of their data slides that we got. So it is a class 2 uroflowometry device available on smartphones. for screening, medication monitoring, and pre and post-op procedures. So again, I didn't talk about this, but what I utilize it for as well is what we used to have to do for our Euro lifts, resumes, our hole ups is, we would do a Euro cuff before and then a Euro cuff 90 days after. I don't know if y'all have had this situations, but most of the time, if my patients are doing well, they don't come in for that 90-day post-op. So if they have something that's easy to do from their phone, they're much easier to actually follow through with the flow monitoring. Seamlessly transfer the patient's data clinician dashboard. That's all the data that I was just showing. But you can kind of see here, this is the one that was an aquablation. So that an IPSS score of a 24, 6.6 mils per second was their max flow rate, 160 voided volume, and then voiding time. Look at this, almost a minute to empty their bladder. Then post aquablation, IPSS score was a 7, 230 mils voiding, 22.5 mils per second. Voiding time was 17.3 seconds. So they are actually emptying their bladder better. So this is a QR code, and I know Vic will have this saved up and then released to y'all as well. But this is something that you can scan, and you can actually have your patient scan, and there are trials available. So you can actually do a 1-month evaluation access. So this is before I actually started giving this to my patients. I did it for myself. I compared my ProudP data with Euro cuff data, and it is very accurate. So there's no wires, no cups, just sounds. And I'll play a quick video here. Let's see if I can get it to play here. So pretty simple to use. I will say I was a little nervous about like my older patients utilizing this, but they've done a phenomenal job and able to do it. So when I start to consult my patients about BPH, I kind of talk about TERP. I talk about how it was invented in the 1920s. I talk about our smaller gland sizes. I'll talk about, resume, Urolift, and then obviously I move into aquablation. I utilize all of the tools. Again, I'm really emphasizing tools here. So in our clinics, we have these things called wall boards that I will also draw all over. I'll draw the trabeculations in the bladder. I'll draw urine left over in the bladder. I'll actually draw a Urolift opening up the prostate, or an aquablation kind of power washing the prostate. We have trifolds on all of our stuff that we utilize for our patients. And even on those wall boards, I didn't have a picture for this slide deck, which I probably should have. I have a ProudP advertisement that we created with Soundable Health that has a QR code that they can actually share their data with us as well. So when I'm talking to my patients, I utilize a lot of analogies, and this is all really to get my patients into an effective, durable treatment. So my mechanic analogy, and this is how I introduce cysto trust and why they should move forward with a cystoscopy and trust, is if you have like something in your engine and it's clinking around, and you go to your mechanic, and the mechanic's like, I've seen this 1,000 times, here's some new oil. That's us trying medications. We don't know what the problem is, and we're just going to try something to see if it actually helps it. What you really want the mechanic to do to get underneath your engine block, take a look and figure out the problem. And that's how I introduce cystoscopy and transrectal ultrasound. Clogged toilet. This is how I talk about retention. And whenever I talk about your toilet being clogged, I'll say, when you flush your toilet, where does the water go? It goes outside the bowl, right? And that's when I start talking about hydronephrosis. And I'm like, you need to remove the clog in the drain. And, using Drano is like using, some of the medicines. If y'all have you ever used Drano at your house, you kind of know that it works about 20% of the time. But what you need to do is you need to either plunge it or snake that drain. And that's where I really introduce our treatment options like aquablation and Urolift. The rings of the tree, this is how I start talking about trabeculation and bladder health. The more severely trabeculated the bladder, the longer standing BPH has been going on. So I talk about a tree being cut in half and how you can count the rings of the tree and see how old that tree is. That's how old the bladder is, or how long the bladder has been working through an obstruction. And I have some slides later about the trabeculation of the bladder. Cleanup batter. So this is really kind of my plea at the very end of the procedure, and especially if I'm moving forward with aqua, because our patient satisfaction and our patient experience has been just so glorious with aquablation. So me and the other APPs cover overnight call for our patient population. So when we really started doing aquablation therapy, we saw a huge decrease in calls related to their BPH treatments, mainly blood in the urine, dysuria, when am I going to get better, all of those things. So we've just been we're very happy with aquablation therapy. We have to undo generations of fear. Today's BPH treatment is not your grandfather's. I don't know how many times y'all have been told, like, I'll have a patient come in and be like, oh no, my buddy Mark had some surgery on his prostate. I ain't doing that. He was never able to walk again. And all these kinds of ludicrous statements about BPH, when, it's really about us educating these patients that there is newer therapy out there, and that, the UroLift has, zero sexual side effects, but, you may not get as long. Aquablation has, some sexual side effects, but the numbers are looking a lot better compared to the other resection procedures. So it's all about us educating. And a lot of times my guys will think like a simple prostatectomy or an actual radical was a treatment for BPH, when that's not the case. So these are real world images that I have from my clinic. So these are all from my cystoscopies that I completed. All my patients are awake for these. So I will actually show them these pictures on the monitor. And that at the bottom where it says healthy bladder worsens permanently damaged, that is a clip from UroLift's pamphlet that we utilize. So basically what I'm doing is I'm doing the cystoscopy and I'm making the patient look at the screen. Now, obviously, I'm not going to turn their head and force them to look at it, but I really want them to see the state of their bladder, because then it is going to help me, and again, utilizing my tools, kind of convince them to move forward with the procedure. So the far left one was one of my most memorable. This is a cardiologist that his urologist had retired, and he'd been on dual therapy for about 20 years. He'd been on finasteride and tamsulosin, and his urologist retired, so he just needed somebody to take over his medicine. So he came to me, and I did my whole thing. His IPSS score was around a 15. His PVR is what caught my attention at 300. And I asked him, I was like, when have you done your last cystoscopy and transrectal ultrasound? Excuse me. And he told me he had never done one. And I was like, okay, well, we need to get you in and assess you. So, excuse me. So this was his cystoscopy. And you can kind of see the trabeculations there are so fibrotic, that's permanently damaged. He was kind of on the cusp of potentially having to do self-catheterization. So whenever I showed him that, he kind of teared up just like I just did. And he was like, why did I not have a cystoscopy before? And, I was like, well, we're here now. We can treat you now. And he ended up doing an aqua with us, and he probably never got his bladder health back, but we got him to empty better. That second picture is like a grade 2 trabeculation. And that third one's a big, juicy median lobe. And my point of showing you all this is, you can see whenever I show my patients this, and then after that, I'm talking to them about this, and they say, oh my gosh, I see the healthy bladder. My bladder is not looking like this, and I'm already on medications. What's next? So my actual surgical conversion rate, so why ProCept got very interested in me, and subsequently ProudP, is my surgical conversion rate was actually around a 49% once I did the cystoscopy and transrectal ultrasound. So what I found is, they asked me, what do I think my surgical conversion rate was? And I said 20%, and their mouths kind of hit the floor because you can see here, national average is 1 to 3%. So whenever I told them the 20%, they kind of said, that doesn't sound right. So I thought I was kind of a liar. So I went and pulled all my Cysto Trust data from 2023 and 2024. And again, I was a little underperforming for 20%. It was actually closer to 49%, which meant 1 out of 2 patients, if they do a cystoscopy and transrectal ultrasound, they moved forward with some kind of surgical intervention, whether that was aquablation, UroLift, Resume, HoLip, or a TURP. They moved forward with something. So my plea to everybody on this webinar is really, 1, to try to get APPs to do more diagnostics with cystos and trusses. And I've seen throughout my workings with ProCept that this is a mountain that can be climbed. It's just people don't know how to do it and how to get it actually into action. Or if that's not the case, talking about a cystoscopy and transrectal ultrasound and getting them in there, mainly to check for bladder health. That's the biggest thing. Earlier intervention. You want to scope these patients at, their IPSS score of a 10 and not wait for them to get to 25, 30, 35, because then the bladder health is kind of, damaged and you can't kind of come back from it. So this is a quick overview of my patient care pathway. So if it's a BPH consult or anyone that's 50 or older, they start kind of going down this pathway. So an IPSS, PVR, UA, DRE. If they're not on medications and their IPSS score is above a 10, 1 month trial of an alpha blocker. You'll bring them back in a month. You'll repeat the IPSS, PVR, and then potentially they will do a Urocuff or ProudP at that time. If obstruction is confirmed, you start doing the cysto and the truss. If they're already on medications, discuss side effects, wean them off of their meds. So if they're on dual therapy, I'll take them off their finasteride. I'll bring them back in 30 days, repeat their IPSS. If they're only on an alpha blocker and their IPSS score is nice and low, I start to talk to them about their meds, and then I bring them back and I repeat their IPSS score. Or I have them do ProudP, and then they can document their IPSS scores there. So 30 days later, I'll recheck their IPSS score. If it's worsened, it's confirmed BPH, you do the Urocuff, ProudP, cysto truss. If no change, ongoing surveillance. I've had this happen many times where I've had a medicine from primary care I've had a patient from primary care and they had been on tamsulosin or finasteride and their symptoms never got better, right? So they have an IPSS score of a 12 and maybe the bladder symptoms, the frequency and urgency are higher than the weak stream and straining. And they were just misdiagnosed as BPH because if we're going to throw a dart at a male, then more than likely it's BPH that's their problem. So I'll wean patients off their meds and their IPSS score doesn't change. So I'm not going to move them down to go do cysto truss, all those kinds of things. Maybe they need an overactive bladder pathway. So if they don't change on their IPSS score after you take them off their meds, you can, ongoing surveillance. Discuss surgical options after you have all your data. So this is where I love being able to teach my other APPs because our surgical options are pretty simple. Anything that's 30 grams or less are your minimally invasive procedures, right? Your Resume and Urolift. 30 to 50, I kind of say all options are on the table. I will move them into certain directions that I feel like would be better beneficial for them. But you can either do a Urolift, you can do a Resume, you can do an aquablation, you can do a TURP, you can do a HOLUP. But aquablation is our pride and joy. So anything above 50 grams is an aquablation unless proven otherwise. So out here in Texas, we still have the cancer portion of it that you can't do an aqua on. So if I have, a 50 gram prostate that has moderate obstruction, that they do have a history of prostate cancer, they can't do an aquablation. So that may be, a TURP or a HOLUP or something along those lines. But that's my pathway. I fine-tuned it to where it's pretty easy to follow. My other APPs that I've trained have had a very, very, very good understanding in how this kind of works. And I will say my most proud moment is that we have yet to sign up somebody for the wrong surgery. So we're doing all of these workups, and this sometimes surprises other APPs and surgeons alike. Sometimes they're meeting the surgeon the day of surgery, and we just elude this confidence, and we know kind of what the steps are and these check boxes are that the patients are very comfortable with that. This is a quick video of kind of my pathway that I utilize here in Austin. This is our clinic at the main part of Austin. Hello, everybody. My name is Alex Hughes. I'm the lead nurse practitioner out here at Austin, Texas, here at Austin Urology Institute. I'm going to walk you through our BPH care plan pathway. This is our clinic out here in Austin. This is the patient checking in with reception. This is where they can start giving their insurance cards, insurance verification, and driver's license. After he's been checked in, he will wait in our lobby where we do have BPH and urology reading material. The MA will call him back, walk him through, and the first stop is going to be to the bathroom. We do need a urine sample. The biggest reason is we want to see what his PVR is. So that's post-void residual. This is performed by a bladder scan. So after the patient leaves a urine specimen, we'll do a urinalysis on it to make sure that there's no urinary tract infection. The medical assistant has brought him back to the room. She's performing a bladder scan, as you can see in the video here. This scan takes no longer than 10 to 15 seconds and checks bladder dysfunction. So in our practice, anything above 100 needs to be evaluated. So this patient had around 200 PVR, which shows some severe bladder dysfunction. So the medical assistant will dictate it here on the chart, and then we'll give the patient an IPSS score. The IPSS score is the International Prostate Symptom Score. The scoring sheet is a score from 0 to 35. 0 to 8 is mild, 8 to around 20 is moderate. Anything above 20 is severe symptoms. This patient has checked off that he is severely symptomatic, which is why he is here. He's here for nocturia and dysuria in a weak stream. So taking him down the BPH care plan pathway is the right appropriate thing to do, especially with that PVR of 200. As the patient finishes his IPSS, he will give it to the medical assistant. At a later date, we may do a urocuff test. This is a urine flow measurement. It checks the mils per second on his urine flow. If the patient shows an obstructed urine flow, which he does, which we will review later, he needs a cystoscopy and a transrectal ultrasound. The cystoscopy is done by one of the providers, either APPs or the MD. It's a small bore camera that goes through the penis and looks at the obstruction of the prostate. It takes about 3 minutes, and then we'll need to do a transrectal ultrasound. The ultrasound takes about 2 to 3 minutes on the backside and takes an exact view of the prostate, and that's how we get the volume done. After this, the physician will have everything he needs to do to give the appropriate diagnosis. It's very little discomfort, but it is worthwhile, and it does give us a lot of data. So here the provider has all of the information he needs. He has the IPSS score, which is severely symptomatic. He has the Uroflow study that shows obstructed flow. And he has a PVR that's above 200, which shows some severe symptoms. So we'll do a medication trial of alfuzosin or tamsulosin and bring the patient back. This patient's IPSS score has decreased, but it is not perfect, so we can confirm the diagnosis of BPH. The medication would not work if he did not have that diagnosis. So this is when I really start talking about aquablation therapy and a surgical intervention. I review our wall boards and teach them about aqua. After they've done the aqua, we bring them back and do another IPSS score. As you can see, he's scoring a 1 all the way from severe down to mild, and he's extremely happy with the procedure. This is our BPH care plan pathway. Not every patient follows this exact way, but as you can see, the patient is extremely happy with his aqua therapy. Thank you for listening. Hello, everybody. So that's quick and dirty. Now, obviously, that video was made before we really started utilizing ProudP. And you can see even on that video where that Urocuff was, the nurse is standing there with the patient, which was me, and it can be awkward. Now, I will say that the same pathway I utilize is the same thing that I do with ProudP. So whenever I have those urine flow data, I'm having that. I can do it over telemedicine. So my recommendations, talk to your patients about side effects of medications and the success of surgical interventions. We've been highly, highly, highly successful in terms of surgical interventions. And, it helps patients much, much more than just medications. And I don't know about y'all. I get tired of just saying, here, let's just do an auto renewal. Let's get you on some more of these medications. There's nothing out there that has been really kind of coming out that's going to take place of surgical intervention. So really talk about the side effects. Encourage early cysto because it's not actually early. So whenever I do these and their IPSS score is like a 12 or a 13 and I start talking about cystoscopy, they're like, I'm not that bad yet. And basically what I tell my patients is like, prove to me that it's not that bad. Let's take a look at the bladder health. It is, I know my video said 3 minutes and then 3 minutes on the truss. Literally, they are done and out of there on both sides in less than 2. So it's minimally invasive. We use lidocaine in the urethra, all of the stuff, get them in there and get them to do an actual scope. Use your tools. That's basically what I want you to come through this slide deck in this presentation. Utilize all of your tools, your IPSS scores, your PVRs, your ProudP, your Uroflow, your Urocuff, your DREs, all of these cystoscopies and transrectal ultrasounds. These are all so important to getting the full picture of the patient. If you haven't seen a cystoscopy, if you haven't seen a transrectal ultrasound, or if you haven't seen one of these BPH cases, talk to your surgeons, try to get in there and see an aqua, get in there and see a terp, get in there and see a holeup, get in there and see a green light. You know, once you get in there and you can actually see, it's much easier to talk to your patients about it. And if your surgeons or MDs, you know, want you to do cystoscopies and transrectal ultrasounds, try to do it. It is a great procedure. It is not easy to learn, but it is not unteachable. And it gives you a breadth of clinical skills that you can offer to your patients. Talk to your surgeons and your MDs about patient care pathway goals. Evaluate your patient education process. Talk to your patients about side effects of meds. Educate patients on bladder health and irreversible damage. That is the most important that I could really relate to y'all. And educate the entire office on this. So one thing that we do in our practice is lunch and learns, where every month one of the APPs will teach the clinical staff about a topic. You know, obviously I probably do BPH most of the time, but with staff turnover, it's always new, it's always good, and the MA staff will really utilize it. But I'm talking even the receptionist. The receptionist needs to know if somebody's calling in and saying, hey, do you do this water therapy, that they mean aquablation. So educating the entire staff as well. So those are my recommendations. This is all of ProudP's, you know, data that they have, and this can be available for y'all as well too. But that's it. I really, really, really appreciate y'all having me on here. I absolutely love BPH, and I love talking to other APPs, surgeons about this kind of stuff. So if y'all need anything, I am available. Thank you.
All right, Alex, that was a great review of BPH and ProudP. Just going to start off with some questions and comments. I've seen some coming here through the audience. You're talking about aquablation. Somebody did ask, why is aquablation contraindicated for non-metastatic prostate cancer?
So that's Medicare guidelines. And it's slowly going to get some relief of that. I think 2026, 2027 it is. And it's just how the FDA licensure kind of works out. You know, whenever they start doing all these clinical trials, you know, they weren't doing it on prostate cancer. So Medicare guidelines won't allow it. So anytime I'm signing anyone up, we follow Medicare guidelines. So like some private insurers will cover it. But in terms of over here in Texas, you know, they just haven't covered it just yet.
So it's more of an insurance coverage rather than medical contraindication.
100%.
All right. So now getting into the ProudP. For those new to ProudP, which would be probably most of our audience, can you briefly explain how it works to measure urinary flow just using a smartphone? Which I did download that app, so I'm going to. Drinking my coffee, I'm going to try it.
It's fun to use. Yeah. So basically, what it does is it uses audio to listen to the urine flow hitting the toilet water. That's how it can give you a urine flow from that, and it actually gives you a urine volume measurement from that. So basically what you'll do, and again, like you said, I have it on my phone as well too, and I'll actually show patients how to utilize it, not in the toilet, but I'll put it above the sink in my clinic office. And so you'll turn it on, and it has a big start button. And so whenever you're in your bathroom, you put it like on the toilet, you know, kind of the top of the toilet or the sink right next to it, just so that it can hear it. And you'll hit start. It'll count down 3, 2, 1. You start your urine stream. You do have to be standing for it. So I have had patients be like, well, hey, how about I sit to urinate? And I'm like, well, not when you do the ProudP. We need to get something where you're standing to do it. And you pee into the toilet bowl, and then as soon as you're done with your last drops, you hit finalize or stop, and it'll actually give you your urine flow from there. So yeah, it all uses audio. So obviously you want it to be in a quiet environment. You don't want it to be, you know, the TV being loud or those kinds of things. So whenever I do it in my clinic and I turn on the water, you know, it gives me obviously a urine flow of like 500, but I'm just kind of teaching the patients on how to do it. And I've had, you know, I think my oldest patient that's done it is 98. So, you know, it's not as difficult in terms of technology wise as one would imagine.
Yeah. It's just mind blowing that it can get a Uroflow from a microphone.
I know.
And somebody who's done urodynamics his whole career. I mean, it's just like.
And one thing that I did do is I compared it. So I did a Euro cuff test on myself and did ProudP on myself as well. And it was very accurate. The volume on the ProudP may have been a little bit lower, but I also may have just been urinating a little bit lower on that one as well too.
Now, does it have to be urinating into a toilet so here's the I think
The
against the
water.
water? So you couldn't do it into a measuring cup or something.
Correct. Yeah, it has to be the water in the toilet. So yeah, like a urinal wouldn't work. So if you're out and about and
Yeah.
I don't know how many people would want to do it at the urinal, but it would be best to do it at home at their toilet and urinating into that water.
Yeah, that's really great. I had a guy on the show who's a therapist for periuresis, people that have that shy bladder syndrome. And
Exactly.
actually he was the president of the international conference of that, and I didn't even know that existed. So it was neat to have him on. But that was brought up because of a question one of my viewers sent in about the Eurocuff. He was scheduled for a Eurocuff. He says, I suffer from shy bladder syndrome. How am I ever going to do this test? And I said, it's true. I mean, those of us who've done urodynamics, you've got a very unnatural situation that you're trying to test, and it's just not going to give you the best results.
And exactly what you're saying, Vic. It's like if you have a patient that is like, what I always will say, like they'll come in and they'll be like, I have a nervous bladder. That's what it is. So like anytime they see a toilet, it's like they feel like they have to go. And I will bring up Pavlov's dog a lot. And I'll be like, that's kind of what it is. It's this mental cue. So if you're trying to, because the last thing you want to do, in a lot of times, my patients that have a nervous bladder have some form of anxiety. You can almost equate it. You'll see, the benzos or something along those lines, or they'll even tell you, I'm just an anxious person. And so the last thing you want to do is start scoping those patients, especially if they're, prostate, if they're, 30 years old and you're like, I don't want to have to shove a camera up this guy. I don't want to have to do all that. I mean, I guarantee you his prostate's, the size of a small grape or what have you. That's where it really puts the data in the patient's hands, and you can start doing it from home. And it really kind of puts, all of the data from there, because you'll see their urine flow is great, but they're just peeing all the time. And you start to utilize it as a bladder training, device more than anything.
Yeah. Yeah. That's really neat. Did have some questions coming in here, so I want to run through some of those. Ron Gracilla on YouTube said, I've been using it for 2 months. It's super easy and also gives trends of volume and flow over time.
Yeah. Awesome.
Which is unheard of doing a urodynamic study. You're not going to get trends.
And that, so like, I was an ICU nurse, the bulk of my career. So one thing, if I have any ICU nurses on here, is intake and output, right? So you have catheters, you have, all the fluids you put into the patient. So intake and output was kind of like my thought process, even going into urology. And whenever I'm trying to figure out, are these patients having some mismatch there, they you can really utilize that. So a lot of times, I'll have my patients do a bladder diary, right? And so again, I think I mentioned it, even during my presentation, these patients that are drinking a gallon of water, I mean, they're going to be peeing all the time. And, and it's what you put in is going to have to put out, or you want it to come out. So that's where those volumes can really kind of shine a light. Hey, is this a problem that you're doing to yourself? And then you can manipulate that problem at the house.
Yep, absolutely. One of the things I find that's probably the most underutilized and probably gives you the most information is a simple bladder diary.
Yep.
I mean, you can find out so much. As you said, people are drinking a lot of fluids these days because it became fashionable. And for some reason, most of us in healthcare kind of know if it goes in, it's going to come out. But general public, they don't realize it. Like, why am I going so often? Well, quit drinking a gallon of water.
And a lot of times what I start talking to my patients about are the bladder irritants. And, and these things, often get, not discussed as much, but coffee, tea, soda, energy drinks. I'll have patients that will come in and they'll be like, yeah, I'm peeing, 15 times during the day. And I'm like, well, what are you putting into your body? They're like, well, mainly water and, 6 Red Bulls. And I'm like, okay, maybe that could be part of the problem, And so again, with ProudP,
Yeah.
I can start having them equate, every time they're urinating, and then they can start decreasing their bladder irritants. And a
Now,
lot of times
ProudP also has a bladder diary part in it,
it
right?
does.
Where
Yes, sir.
patients can log with their inputs.
They can, yeah. And one thing that I know that they're working on, and what I've really, really wanted them to do, is a way of messaging their provider. So I think that they're on the queue of working for that thing. Sorry, I keep on getting on this sun on my face. So I think that would be really great. But yeah, there's a bladder diary on there. There's IPSS scores. Obviously it's going to, document every urine flow that you measure. That's the other thing is, and it'll document even if it's less than 100, but there's like this little, tick mark that you have to pick. And if it'll only show you ones that are above 100, but especially my true patients that have true overactive bladder or nervous bladder, they may be going to the toilet and peeing out 70 cc's.
Sure.
So you can actually unclick that and it'll show you every one of them.
That's great. And so the results that are brought in, they bring your phone in to see you, or that's how they get the results, or
there's a dashboard. So whenever they scan their QR code, they select the urologist. So the urologist does need access to that. So like whenever we started with ProudP, they built us a dashboard. And so when they scan the QR code, they can select a urologist that has already have their dashboard set up, and then it's reported to me. So I have a dashboard of like all 60 patients that we have so far, and I'm following them constantly. And another thing that will happen, again, I'm a little too active in terms of my patient care. Sometimes my family would say I work a little bit too much, but I will look at that stuff. So if I start to see these urine volumes and they're coming in and they're all 15 mils per second or less, and I know they have flow, I'll go into my Athena and I'll be like, what's going on with this patient? And I'll look at it. And, sometimes it'll say, hey, did the cystoscopy transrectal ultrasound setting up for aquablation? Once ProudP data rolls in, and I'll message them on their portal and be like, hey, I see your ProudP data. It's definitely less than 15 mils per second. Do you want to move forward with aquablation? And then they can actually message me on there and be like, yeah, let's go ahead with the orders.
Yeah. And I saw that. I was just signing up while you were talking on the Q from your QR code. And it did say whether you had a urologist, you could click that, or if you're just doing it on your own. So apparently that information will come to me only because that's what I clicked.
Yeah, and they do release, like, I think November Men's Health Awareness Month, they will release like a special where you can do your own testing. So yeah, you don't have to have a urologist at all to do this. But if you do, you can actually, and they are signed up with them, because that's the other thing. So if you do have a urologist and you do want them to sign up, that's a discussion you need to have with them so that they can actually get your data and utilize it. But if you just have your own data, and you can send it as a PDF to your urologist, at least at my practice, I could utilize that. And not only because I'm a part of that team, but it is a FDA approved urine flow. So you can actually use it for insurance.
Well, I just had a question came in from Susie Swain. If a patient uses ProudP, will insurance accept that for surgical planning?
Yes.
All right. So yeah, I tell you, to me, it's just fascinating because I really think that all this monitoring that you can do yourself is putting our own health way ahead of what it used to be. And I've been in urology for 40 years. You and I were talking early on in the before the show started, and I can tell you, there's been a lot of times that you talked about silent BPH. Patients come in and they have no complaints. They probably would have filled out the bladder, score, the IPSS score as pretty normal. And then you scan their bladder and their post-void residuals, 1 liter.
Yeah. I've had it many times at my clinic.
And at that point, it's too late. Their bladders are pretty well shot. They're going to either be intermittent catheter or permanent, long-term catheter drainage, and hope that the bladder gets some contractility back to it. But, it's being able to monitor this stuff, I think, is going to be huge. And I'm a big proponent. I have the Apple Watch just to keep track of, my sleep habits, because there's more and more data coming out about how you can do simple things to intervene that are going to have a long-term health effect for you, such as exercise. And sleep.
Yeah, and like one of our health insurances, I signed up for it, and it had a thing where you could get a free scale. And so now, like even like with your CHF patients, right? So you need to monitor their weight, you need to do their blood pressures, and all of this is electronically submitted to their cardiologist or their primary care. So home monitoring is where this whole area is shifting. And it's just crazy to me that you can do a home monitoring urine flow measurement, but it's fantastic that you can.
Yeah, it is. And these things, I think, especially non-invasive tests, anybody who's done these procedures like urodynamics, where you've got to catheterize patients, that's far from non-invasive. So
100%.
So, well, Alex, it's been a great talk. I look forward to having you back on. I think we'd like to get you on to talk a little more about your aqua ablation, your BPH pathway for this group, and maybe get you on my Uro patients to talk more about the ProudP.
In this free one contact hour episode of UroNurse, we explore how treatment for urothelial carcinoma and muscle invasive bladder cancer is rapidly evolving. Traditional platinum-based chemotherapy has long been the cornerstone of treatment, but a paradigm shift is underway with the emergence of immune checkpoint inhibitors, antibody drug conjugates, and combination regimens. The first-line approach to locally advanced and metastatic bladder cancer is being redefined. Doctors Andrea Polo and Daniel Petrilac review clinical trial data and discuss patient selection for new combination therapies. What does this mean for urology nurses, oncology providers, and patients? Join us on November 1st at 9 a.m. Central Time to learn more.
Well, that's what happens when you get your finger on the button and you accidentally push it. That's next week's show. So that's a little promo
Teaser
for next week's show. But I usually announce that before I hit the button, but my hand was right next to it and it dropped just on the button. It's a pretty sensitive button. So yeah, join us next week. Got a lot of people writing in how informative your talk was. They really enjoyed it. Large viewing audience. Thanks for all the people joining us live. Continue to watch us every week. We're here every week at UroNurse.com. Check out our website, and we'll see you all next week.
Thanks.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the street. And a head full of dreams.